The topic of this presentation is rhabdomyosarcoma. We'll start with introduction. Rhabdomyosarcoma is the most common soft tissue sarcoma of the childhood. 40% develop in the head and neck. It is the most common primary orbital malignancy in children, but is still a rare condition. Approximately 90% occur in children under 16 years, and the average age of onset is 7 years. The tumor is derived from undifferentiated mesenchymal cells that have the potential to differentiate into striated muscles. Various genetic predispositions have been identified, including variants of RB1 gene responsible for retinoblastoma. 4 subtypes have been recognized. The first one is embryonal, which constitutes the majority, about 85% of orbital lesions. Cell may show light microscopic features of striated muscle differentiation. Embryonal usually carries a good prognosis. Number 2 is the alveolar, which makes up most of the balance of orbital rhabdomyosarcomas. Fewer cells show skeletal muscle differentiation than embryonal, and the prognosis is worse. Particular chromosomal translocations are characteristic on cytogenetic analysis of biopsy material. Then number 3 is thyroid, which is about 4% of the tumors. And number 4 is the pleomorphic rhabdomyosarcoma. They are much less common in the orbit. Rhabdomyosarcomas can mimic an orbital infection in a child. Now, patients present with rapidly progressive unilateral proptosis, and it is usually they mimic an inflammatory condition such as an orbital cellulitis. The tumor is most commonly supranasal or superior, but may arise anywhere in the orbit. As you can see in the top picture, the lesion is present superiorly, but in the bottom picture it is inferiorly. The location can change. It can also arise in other tissues such as conjunctiva and uvea. Swelling and redness of the overlying skin develop, but the skin is not warm, as it happens in inflammatory cases. Diplopia is frequent, but the pain is less common. MRI shows a poorly defined mass. CT also shows a poorly defined mass of homogeneous density, often with adjacent bony destruction. As it is shown here in the picture, you can see an irregular mass and with this bony destruction here in this area. Incisional biopsy is performed to confirm the diagnosis and establish the histopathological subtype and cytogenetic characteristics. Systemic investigation for metastasis should be performed, with lung and bone being the most common sites. After that, treatment. Commonly used guidelines for staging and corresponding treatment protocol were produced by the Intergroup Rhabdomyosarcoma Study Group. Treatment encompasses a combination of radiotherapy, chemotherapy, and sometimes surgical debulking. The prognosis for patients with disease confined to the orbit is good. So that's it with the rhabdomyosarcoma. If you like the lecture, please click the like button and subscribe to the channel. Thank you very much.